Hi, I am Tajwar from Robotics and Control Laboratory at the University of British Columbia, and in this video I will talk about our work on automating treatment planning for prostate brachytherapy. Prostate cancer is one of the most common forms of cancer diagnosed in men, and in 2020 it is estimated that around 1.4 million new cases was diagnosed worldwide. In North America, it is estimated that 1 out of every 8 men will be diagnosed with this disease. For localized prostate cancer, there are mainly two sources of treatment. One is radical prostatectomy, where the entire gland is surgically removed, and the other is radiotherapy, where the entire gland is radiated. So among radiotherapy, low-dose rate prostate brachytherapy is a popular and effective choice of treatment for this disease. In this treatment, basically small radioactive seeds are permanently implanted into the prostate of the patient under the guidance of ultrasound. To do this, physicians use needles to deposit the seeds through the perineum of the patient into the prostate. A template is used for guiding these needles, and this template has 11 by 13 discrete points where the needles can be inserted. And these points are spaced 5 mm apart from each other. Finally, treatment planning in this low-dose rate prostate brachytherapy is the process of determining the arrangement of this arrangement and locations of the seeds that basically delivers the prescribed dose to the prostate while sparing the healthy surrounding tissue. The current challenges of treatment planning includes that right now the treatment plans are done totally manually. So it is very resource intensive because it requires years of training and practice for in order to become an expert planner. It's also time consuming because for every new plan, it takes long planning durations for the expert planners. To add to that, there can be multiple acceptable plans for every case. So due to the possibility of multiple solutions, the acceptability of the plans depends rather on the center's planning preference or style. And finally, because prostate cancer has a low mortality rate, one of the main challenges is to maintain the quality of the plans in order to reduce side effects. So this quality of the plans depends more on the planner's experience. The existing work in the literature mainly tries to tackle the dose volume constraint and dose volume requirement, and they put like little to no consideration for the center's planning style. So hence our objective is to automate this tedious planning process while incorporating our center's planning style and to create plans rather quickly. So the data set we have includes successful clinical planning data of 931 patients who underwent this treatment at PC Cancer Vancouver Center. We have used 761 cases for training, 150 for validation, and the rest 20 for testing. So this dataset includes the transrectal ultrasound images of the patient, and then the prostate segmentation is contoured, and this is called the clinical target volume, CTV. Then we also contour the PTV, which is the planning target volume, and we also know where the locations of the grid points are. We know the location of the seed arrangement, so this is basically the seed plans. We know the locations of the needle arrangement, and that is basically the needle plans. So to simplify our problem, we first try to predict or learn how to generate the needle plans, and we represent these plans as an encoded matrix where each of the pixels in the matrix responds to one of the locations from the template. So then it becomes like a 2D matrix having 11 by 13 pixels. Next, for the input, we basically only use the target volumes as the input and not the ultrasound images, because even at our center, our planners only use this information for generating the plans. And for output, we try to predict the needle plans. First, we binarize all the data. Then we perform Euclidean distance transform on the data to get distance-based information. Then for augmentation, because normal typical geometrical augmentation won't work, because any changes in the input space geometrically doesn't mean the same geometrical change in the planning space. But since the plans are symmetric, we can divide the data in half and then flip the right hand side, and then we basically have double the data. Now this is acceptable because even though the plans are symmetric, the prostate is anatomically not exactly symmetric, so the input data is slightly different for this two cases that we got out of one case. Now for learning the needle plans, we use conditional generative adversarial networks. This is because such networks can automatically learn complex mapping without needing to algorithmically setting all the rules in its loss function. So here basically the generator tries to take the PTV and CTV and learn the needle mapping, and the discriminator takes the PTV, CTV and needle plan pair and determines if they are generated or not. Then for training the generator, we use 4 different losses. One is the L1 loss, which is the L1 distance between the generated and real plans. So this penalizes the model if the plans are not so similar. Then the needle loss, which is the novel loss we introduced in this work. So our center basically doesn't accept a few needle arrangements, and these arrangements are shown here from kernel K1 to K4. So if in our predicted needle plan, if such arrangements are seen, this function basically performs convolution with the kernels and then finds the pixel where such unacceptable needle patterns are. So then it penalizes the model if it finds such patterns. Next, we have the adversarial loss, which is basically the loss that is added if the generator is producing plans that are not able to fool the discriminator. And finally, we have a feature loss, which is basically the difference between the features extracted from the discriminator's intermediate layer. So it compares if the feature extracted from the generated and manual plans are similar or not. With that, we have the total objective function, which is the weighted summation of the 4 individual losses. Next, based on the needle plans, we want to initialize the seed plans. We do this by placing the seeds on alternating grid points from the template. So this basically gives us a set of seed distribution for every odd and even planes of the plan. Next, for this case, for example, the seeds are not evenly distributed between the planes. So we also have this step where it tries to distribute the seeds between the planes so that there is a more uniform coverage around the entire gland. And as you notice that no seeds can be placed next to each other because our center doesn't accept adjacent seeds. Finally, a simulated annealing method is used to further tune the location of the seeds so that we get the best coverage and we get the final plan. Now for evaluating the results, we do both quantitative and qualitative analysis. So first we need to understand what we mean by the Vx%. So Vx% basically indicates the volume in the prostate that received X% of the prescribed dose. So here the green contour shows the V100%. So that's the volume where 100% of the prescribed dose was given, and V150% is showing the volume where 150% of the prescribed dose was given. So we compare mainly 3 techniques. One is a common Seattle-based initialization with simulated annealing. P2 is our technique, and P3 are the manual plans. So here you can see there are the PTV and CTV V100 and 150 that we compare. These are basically indicating the percentage of the PTV or CTV volume that is receiving the Vx% of the dose. And then we also compare the number of seeds and number of needles we are using in the plans. So ideally we want our plans to have similar numbers as the P3, which are the manual plans. A t-test revealed that P2 is statistically significantly different from the other 2 methods with a p-value of less than 0.05. So to have a better look, we look at the box plot here, and you can see that it's quite evident that P1 has the worst dose coverage and has larger standard deviations. Our method P2 has a similar dose coverage to P3. It has in general less standard deviation and outliers, but our plan uses more needles in general than P3. Next, for qualitative analysis, an expert planner basically rated the plans from the test set, and they basically rated based on dose distribution quality and the target coverage quality. And they basically concluded that 60% of the plans can be acceptable and above, and 15% only was suboptimal and below. And for target coverage, 75% of the plans was deemed acceptable and above, and only 5% suboptimal and below. And we also asked about the acceptability of the plans in general, and they concluded that 90% is acceptable, with 60% requiring some minor changes, which means moving a few seats here and there, and 30% requiring major changes, which means moving more than a few seats or needles. Finally, for conclusion, we propose an automatic plan generation framework using novel loss functions. Our planning times are much quicker, which takes on average 3 minutes compared to 20 minutes for manual plan. Our dose coverage is very similar to manual plans, with 90% acceptability in our center. And this also means that such model can be used in less experienced center, where they use data from more experienced center to basically deploy high quality treatment plans. Thank you for listening.